Swigs, you made it to the last session of the day. You survived day one of the Post-TB Symposium. And this session is actually going to be another really exciting and important session. We've got Greg Bisson, who's going to be presenting the research definition. And then we're going to have some time at discussion, aiming to end at 5 o'clock. So we look forward to that discussion. And I'm going to hand over to Greg, who seems to be almost ready to go.
All right, thanks everybody. Thanks everybody for coming. Let's see, I get this into view. Isn't it supposed to be showing on this? Okay. So, oh, there we go. Okay. Hi, everybody. I'll just get ahead and start in the interest of time. I would like to say today I'm going to be talking about progress towards a research definition of post-TB lung disease. When I say a research definition, a definition that's specifically meant to be used in research investigations. I would say that I was told that I would have about 35 to 40 minutes to present, and then I had this great idea last night that at 8 p.m. I would cut my talk down to about 15 or 20 minutes, and the idea for that came in the form of a text from Sarah and Becky and Brian at 8:30. So my great idea, but I think they're right, because I think what you want to do is, this is a symposium, and I want to present this idea and get feedback, because the idea is a definition that we would use in research studies, and it's not going to have any impact on harmonization unless it's used. So this is ongoing work that it was essentially started at the last symposium, where the idea of a definition and standardization and harmonization for research purposes was first explored. And so I'll go a little quicker than usual, or make it a little shorter than usual, and hopefully people can give feedback and we can talk about the ideas, because there's no right answer for doing this. It's just a matter of trying to figure out how to agree with something that we can work towards. And I wanted to show this pathway, which is, this is a journey, so this is something that's going to change over time. So PTLD is a very heterogeneous condition. We've learned about that, and this just shows great diversity of findings when you look at patients with imaging, lung function, and symptoms. This is from patients in one of Sarah and I's studies in Johannesburg after treatment completion. You can see there's a variability in what you see on chest imaging and the symptoms that patients have in lung function. And we've all seen patients, for example, this patient has a large cavitation on the right side. Patient somehow has normal lung function and is asymptomatic, but sometimes it's the type of patient you're wondering how much they're really moving, and so it's all very imperfect. But we know that there's great amount of actual clinical heterogeneity. There's also an extensive amount of heterogeneity, though, in the way that we're measuring PTLD. And for example, if we just think about spirometry, one of the main ways that we assess PTLD, in a lot of ways, we're using different approaches to measure and then interpret lung function findings. And one of the key points of the talk is that if we don't know necessarily, as long as we're following guidelines for ATS or ERS guidelines for interpretation of lung function, we could be doing it the same way and reporting it the same way so that we can harmonize results. But you can see here, this is from a meta-analysis published in 2023, just looking at the variability of how lung function is reported. You can see some studies using % predicted values and other studies using lower limit of normal. Some studies defining patients of having obstruction or restriction, and some studies not. Some studies just reporting the mean FEV1 and % predicted values. So there's quite a lot of heterogeneity. So for the Camilla Romanowski and all the people who do meta-analyses of data, one of the things that they often say in their studies is that there should be standardized definitions for evaluating these syndromes. There's just two examples there. But heterogeneity in these studies, sometimes captured by the I-squared statistic or in other quantitative ways, really arises kind of from two things. clinical heterogeneity. The patients could be different. The time points when you assess them could be different. Some could have HIV, some could be rural. There's many, many different reasons why you could see different clinical manifestations, but there's also differences in methodology. And so I think one of the, sort of again, the key point here is, to some extent, we could standardize some of our methodologies in order to try to improve harmonization, and so we can compare results from one setting to the other. There's nothing certainly wrong with diversity and richness in assessing patients with multiple methods, but to some extent, if we are using the same methods, we could report them the same way for harmonization. So this idea of creating a PTLD research definition, just in a nutshell, it's the idea that in studies that we do, whatever outcomes we want to look at, we look at those outcomes. If we want to look at CT scan fibrosis, or if we want to look at a very elaborate symptom score, we want to look at socioeconomic status, we can do that. But to the extent that we're measuring symptoms, or that we have the same data, we could include, in addition to the hypothesis-driven endpoints, some summary measures that everyone's using. So it doesn't have to get in the way of anything anybody's doing. It doesn't have to replace anybody's hypothesis-driven approaches. But it can be something that we can add along to it, so that in addition to whatever specific studies want to look at, we can look in the appendix or secondary outcomes and compare results one study to the other. So if you're going to define a syndrome like COPD, for example, ideally you have long-term data to evaluate. So with COPD, you can look at the percent predicted FEV1, and you can say lower percent predicted FEV1 is associated with survival. Or you can say the MMRC score greater than 2, or whatever cut point you want to use, that's associated with survival. But we don't really have great data like that in TB. So we don't have great information on things like cut points and specific tools to use. If we did, this would be easier. So when myself and others started thinking about a definition, we thought, well, why would we do this if we don't have long-term data? And I think it was Brian that said we shouldn't let the lack of data get in the way of creating a definition, because along the way we can harmonize. And if we harmonize, we can improve meta-analyses and interpretation of the evidence base, as I've said. We can improve understanding of PTLD pathophysiology and risk factors, and that should hopefully improve development of interventions. And I think right up front, as I showed the journey slide there, we a priori accept that this will evolve over time. If you look at the definition of COPD, it's evolved over time, and it's continuously evolving as more data come in. So if we sort of unpack the term post-TB lung disease, we can get real specific about it. And since the second symposium, myself and others, and at the second symposium, people who attended that meeting and attended the workshops did unpack it, and we thought about each term of it. So it's post-TB lung disease. Did the patient actually have TB? Do they still have TB? And does the patient actually have lung disease? For those of you who have studied TB-IRIS, INSHE came out with TB-IRIS definitions, and one of the first things that you look at in the definition of TB-IRIS is that the patient had antecedent TB. So we could do that in some low-hanging fruit for assessment of post-TB lung disease. And I think one of the key things that we really wanted to think about was, are we studying actual disease? And we think about the National Cancer Institute definition of disease. It's defined as an abnormal condition that affects the structure or function of part or all of the body, and this is a key point, and is usually associated with specific signs and symptoms. So it's kind of multiple things. So if you think about PLTD, let's say a patient had an FEV1, just for ease of interpretation, of 75% predicted. They had a clear chest x-ray and they're asymptomatic. So is that disease or not? And does that correlate with long-term outcome? It's easy to say a patient with an FEV1 of 50% and destroyed lung who has a chronic cough has PTLD in some instances, but it's really trying to put these together and trying to improve the focus on patients on disease. To some extent, that's the work of what we've been trying to do with the definition. So this started at the last symposium, actually started prior to that symposium, exploring this idea, something we could develop. I think that's the kind of thing that this meeting, this symposium is really about. The PTLD working group that we just did now, trying to think about coming to consensus on how to assess PTLD. this is a good place to start to build consensus. But like that last working group and building consensus on how to assess patients for PTLD, it's really this is a start, and then those ideas get developed post-symposium over the coming months, and that's really what we're doing and what I'll report on. So the second symposium was very well attended. There was a fairly diverse group of expertise. We had, there were working groups, and this was a topic that was developed there. And when I say we, this is the group that has been meeting fairly regularly since the second symposium to develop this. Sarah, Brian, Jamila, Becky, Celso, Nilima, Gunnar, Marika, and Anthony. So what were the methods that we used to develop this? The second symposium methods. So we sent out pre-conference questionnaire to individuals. We queried people for their emails and sent them out questionnaires. I think we got about 10 responses. And then so what happened was I introduced the concept on the first day of the symposium and did a real-time data collection, sort of like Ant did with the Delphi and the treatable traits, which was just collecting data on how people felt about a research definition. So that was introducing the concept of day one on the symposium. We then went into workshops, which was 2 hours and attended by more than 100 individuals. We talked about concepts, what people liked about a potential definition, what they were worried about. I mean, inherently, who is anyone to say what is PTLD and what's not PTLD? So we had to address those types of things. And then we assessed consensus on the final day and the closing plenary. So this is the first question. So this was 88 people responding on the first day. So the question was, do you think that there is a need to agree on a more specific definition of PTLD for use within research studies? So again, I want to say that I contextualized this at the time by saying this is not meant to be prescriptive in any way, like it's not meant to say this has to be PTLD and things that aren't this are not PTLD. It's just maybe could we agree on what we could call PTLD that's reasonable, that we would include in appendices or include in secondary analyses of our studies so that we can harmonize a little bit. And I think already before the workshops, before we really got into it, there was a fair amount of enthusiasm for that. Here's just talking about what would your priorities be in a research definition of PTLD. And I think it's interesting that it is inherently important to grade severity because that's sort of at the heart of clinical medicine. People can have all sorts of spectrum of different manifestations. We're typically worried about the patients whose manifestations are most severe, obviously. So one of the things people were interested in was severity grade. And this will be a repeating theme. People were very interested in having a research definition that was adaptable for use in resource-limited settings. So at the heart, if you're a researcher and you're thinking, we need a definition of PTLD, well, inherent in the idea of like clinical research and epidemiology is that if you think about myocardial infarction and how that's defined, it's a very specific definition with troponin elevations and acute or ECG changes, and it's been validated over time because it's very specific because you want to make sure you're studying that biological entity that's myocardial infarction. So there's this idea to make it really specific, but we don't know what PTLD is, so a thing that came out in some of the discussions was don't make some definition that nobody can use because it's not going to have any impact, especially in areas where there's most of the TB. So we talked about which tools should be used to define PTLD within the research definition. I guess I don't know why, but I guess I was sort of surprised that symptoms was number one, but it was interesting. I was wondering if spirometry was going to be number one, but symptoms was number one. And interestingly, exercise testing was number two. And spirometry was a third. So we use these data to start to build out the definition. When we tried to push people to say, what do you think is the single most important measure determining if a patient has clinical evidence of PTLD? And we said just select one answer. It was pretty much an even split between lung function and symptoms, with a third of the people saying that they're all equally important. So I will say up front, we did not necessarily take these data and follow them exactly and say that, okay, well, exercise testing was number two, so exercise testing has to be in the definition of PTLD. We took these data as a guidance in the months after and said, well, what do we think is feasible? What do we think deserves, maybe future mention for future research? So then we developed these in workshops, and again, this idea of sensitivity versus specificity and useful in research limited settings. At the heart of it, again, is harmonization. And if you're going to make a definition that requires high-res CT scans and lung volumes and DLCO, there's just not going to be enough people who use it, so you won't really have harmonization. So why make something? Why do we don't even know that lung volumes and DLCO are more specific or more sensitive for PTLD than FEV1. So don't shoot yourself in the foot. Complexities of assessments, we talked about that. So, we think that CT gives us more information about PTLD and the anatomic structural changes of the lung. Sure, it does. But is that better for defining PTLD? Is that going to be more sensitive if you looked at it? It depends on the criteria. A major thing that we looked at was, are we measuring true disease? And what's the significance of isolated abnormalities? We talked about that. We talked about it again being complementary to other outcomes and an emphasis on need for reporting. So at the end of it, we phrased it a little differently. We sort of developed two ideas that we would, after workshopping, we sort of thought of this two ways, is that there would be a definition, but really there would be standardized reporting, so that in addition to defining PTLD for research studies as something you could include, we would also have a reporting framework where you could capture some things about the study so that you could be a little bit more transparent about when patients were assessed and what types of analyses were done. So we had 100% consensus thinking that we should have a research definition, and 92% having a severity grade. And we talked about a certainty grade as well, certainty meaning how certain are you that they had PTLD. So I'm just going to go through this in detail, and Brian, I don't know if we want to have, I guess we can get through it and then we can invite people for discussions, but the number one criteria here is the patient had prior pulmonary TB or pleural TB. So this was the first sort of thing that we discussed, and I welcome comments because, of course, this is something it's important. If it's lung disease, there's other types of pulmonary, or there's other types of TB that could affect the respiratory system. If someone had Pott's disease and they had severe kyphosis, or someone had laryngeal TB or endobronchial TB resulting in obstruction, those could result in it. But we chose pulmonary TB and pleural TB. Pleural was the extrapulmonary TB because of its intimate association with the lung. We try to follow WHO standard definitions for TB, and one of the big things here that we can discuss is we decided to include clinically confirmed TB. So not everybody needs to have microbiologically confirmed TB. Because there's a lot of places where they don't confirm TB microbiologically, and if we have to make a decision, we chose to make a decision that was involved in being more inclusive rather than being excluding a lot of patients in lower middle income countries. Now this is a little bit trickier. The patient no longer had TB, so patients aren't getting cultures everywhere. We heard Grant Theron talking about patients not having recurrent TB. So how do we define that? We can talk about this as well. What we're proposing is that you're either cured or completed using WHO definitions, but we add a little bit on there saying that someone should assess and make sure that the patient doesn't currently need anti-tubercular therapy. This is kind of a thing to say, hopefully people can be clinically assessed. And if patients are having a lot of PTLD symptoms, a study's rigor would increase if you could do cultures. So a clinical assessment, we think, would add to rigor. This can be problematic. What about drug-resistant TB where patients don't have cultures at the end of treatment? I don't know a great way around this. There's, ideally, if you're dealing with patients where there's drug-resistant TB, probably if you're assessing them for PTLD, it's probably more important that they do get cultures. But in a reporting framework, you report back as to whether or not that was done. So, just in the interest of time, this is probably the most important concept. We tried to move towards focused study on patients that are more likely to impact health, and I think it was on a call that we proposed a term PTLA. So just pause here for a second. I think it was Brian who first mentioned it. I'm going to blame Brian. Saying that if you look at patients, the idea is they should have two of either abnormal lung function symptoms or radiographic abnormalities. Just whatever combination, so lung function and radiographic abnormalities, symptoms and radiographic abnormalities, or whatever. So what we're trying to get around is patients with just isolated defects that we think may not be clinically due to TB or clinically important. We're not necessarily trying to say that we know that this is better. But we think for transparency, we could say that this would capture patients who, for example, had just an isolated mild FEV1 defect as PTLA. So there's a place in the reporting framework that will come out that will you'll be able to capture this. And I think, if you look at the COPD guidelines, there's a lot of things that are on the edges where they're not sure if patients with isolated spirometric abnormalities, for example, who are asymptomatic, it's unclear what the prognosis of those patients is. I want to say that for lung function, we didn't include every possible metric that comes out of a spirometer. If you have done lung function testing, there's it seems innumerable measures that come out of the spirometer, and if we just included 5, we can talk about that. The symptoms we can talk about, we included the major ones that are included in the CAT and the MRC, and the radiographic abnormalities. We don't necessarily know how to capture those exactly. We don't know if what level of scarring or fibrosis matters, but conceptually, patients should have radiographic abnormalities that are consistent with prior TB that would explain the patient's other findings, either symptoms or lung function. I do want to point out a thing that I think is just tucked away there. It says GLI race neutral equations. I would say GLI global. So GLI is a way to interpret lung function that gets around the idea of people using their own specific populations or sometimes inappropriate populations to standardize lung function. I think that's actually one of the more important things out of the proposed definition is to use GLI, because if we're all using the same standards, GLI is tens of thousands of normal patients. So if we're all taking lung function from our cohort and then we're comparing to that cohort, which is a diverse cohort, then I think at least you compare, the idea is you could use whatever references you want, but if you want to, if in some part of your paper you report GLI-based lung function testing, it'll be easier to compare one study to another. It's also consistent with what's recommended by ATS-ERS now. So this is the last couple slides. Severity grading, we tried to keep it very, very simple, based on Z-scores of lung function and symptoms severity graded by MRC. We didn't have really a severity grade for imaging that we felt comfortable with. We can talk about what are the most controversial aspects. I might as well just leave this up here, but that's the talk cut in half from last night.
Well done. Well done. Is this mic on? Yeah, you actually escaped the duck. I reset him, gave you extra 5 minutes because of we had a
Okay.
Great, Greg. Thank you so much. There's been a lot of work and a lot of thought process and a lot of discussion going in the background to this. And I want to just ask you a couple of things that maybe I'm going to do some preemptive things. And I want to first make a comment and I'm going to ask you a question. So at the first symposium, when you constructed that initial definition for those that were here, we had a long debate about whether we should call it post-TB lung disease or post-TB. We first had to decide a post-TB. We just settled on that. That was the first thing. The second was, do we decide to call it lung disease or lung abnormality or disorder? And we voted on it. We had a Delphi, and at the symposium, this symposium, we decided as a community that we're going to embrace the term lung disease. So one of the questions that I'm going to ask you to just flesh out is, can a disease be asymptomatic? And then why we decided to include this PTLA as a thing. So that's a new concept, and you need to just maybe explain that a little bit as to what.
Yeah, I mean, I think the idea of PTLA versus PTLD, I think a disease can be asymptomatic because it depends on when you're asking the patient about symptoms. So we're not always stressing patients to tell them to go run a mile or walk a mile. If they're sitting in your office and they're asymptomatic, maybe they're symptomatic when they're cooking or getting dressed. So I think disease can be asymptomatic. PTLA versus PTLD, like if you think about the definition of COPD, it starts with symptoms and then it goes on to lung function. So I think what we're doing is consistent with the idea of some precedent in respiratory disease. So I think it's a focus on, if we're going to look at risk factors of disease and we're going to think about who we would enroll in clinical trials, it would probably be patients with more severe disease. So I think patients with more severe are more likely to have 2 of the things than patients with just 1. So what are we going to do with people, if you're doing a study and you don't have all of these? Let's say you do a study of spirometry and symptoms. That's going to be, I think we have to do analyses that look to see how this works, varying the definition. But that's my thought, is that there is some precedent that there should be a combination of things.
And just
I
to
don't know, what do other people think?
So just to add to that, one of the concepts we discussed at length was we don't have the longitudinal data to validate this. And as Greg says, it will change over time. But an abnormality, say that you have spirometric abnormality, but you're asymptomatic and have no radiological change, that may impact you longitudinally 5, 10, 15, 20 years. And if you don't capture that up front, you may lose that opportunity in your studies. Any comments from the floor on that?
Sylvia's got a question right there.
One here, and one at the back there. And Sylvia, where's Sylvia? Sylvia 3. So 1, 2, 3. Can we just take all 3 questions and then Greg can rebut them? We'll take all 3 questions and then we can rebut them as a unit. Okay.
Yeah, hi, thank you. Very interesting. I'm just wondering why signs are not included. So I see the symptoms, but things examining the patient, at least the respiratory rate, heart rate, SpO2, they're not somewhere, or are they supposed to be part of symptoms? Thank you.
Oh, yeah.
Thank you very much. In terms of the minimum definition requiring 2 domains, in line with what Professor Alwood has just said, my comment was, do we think around, if we say that we need 2 to qualify for disease, then do we also get a definition that sort of like says maybe condition for someone who has 1 abnormality and disease maybe for 2? Or do we actually just take the 1 abnormality? Because you have someone has a very bad X-ray or CT as you showed, and we know, for example, even on spirometry, someone can have a respiratory ratio of 0.07, and we know that maybe in 2 years it's going to be 0.68. So if we don't track them, then it's a problem. So do we keep a minimum of 1 domain? Mm-hmm. Something like that. Over.
Yeah, thanks. Sorry if I missed this, but did you say anything about which time point you're measuring these things in? Because, if you say right at the end of treatment, well, is that really post-TB lung disease?
Yeah.
Okay. Do you want to rebut those questions? We'll take a next round of questions in a moment.
Yeah. So signs is a good question. When you look at, I think one of the reasons is, I think clinically signs make sense. I think when you look at meta-analyses of post-TB lung disease or post-TB respiratory sequelae, the vast majority of the studies either do lung function, imaging, or symptoms. So there's just so much more data on those things than there is on signs. So I think that's largely one part. I think for me, it'd just be difficult to come up with criteria for signs. But I can't say that it doesn't matter. It's just there's less data on that, and to some extent, for this first effort, trying to build a little bit off, it's to some extent to try not to change totally what people are already doing. Like if we can just build off and maybe make some criteria for what people are already doing, then I think it gets more. If we say signs have to be check blood pressure this and pulse that, people aren't really doing that yet, at least in the published literature. It may be the right way to do it. It may really help, but it's just there's not a lot of data on that. So for the so one condition or another, I'm not a pulmonologist, but I think that what I've learned from spirometry is there's a fair amount of noise around one measurement, and especially borderline measurements. And in our studies, it can definitely matter with how much effort patients put into it and what result you get. So do we know, like if in that scenario, if a patient has a predicted value of a ratio of 0.7 or 0.68 or something, and have a normal chest X-ray and they're asymptomatic, I would be less convinced that patient actually had PTLD than if they had a big cavity and they have that. I mean, that's just, I guess, some assumptions that we're making. But one thing I may not be clear is that in the reporting framework, which we're trying to keep very parsimonious and simple. We don't want to ask people to redo all their analyses, but just to report on, for example, see that table there, you could report on the percent of patients who just have an isolated PFT abnormality. And then what we should do is then over time, if we do this together, then people who do meta-analyses can come along and take a look and see if that matters, because they would get long-term data. And then the other question was the timing. Sylvia, it's perfect. It's a great question because obviously things change over time. And Jamila's studies, with good long-term, Becky's studies of 3-year follow-up. I think the way we handled that is we really thought about that. I mean, you could even say, like, after the intensive phase of TB treatment is done, like let's say it's a 6-month therapy, do we really know that 4 months into therapy, and they're still on treatment, but most of their TB is gone, you're really treating for them to those few persisters so they don't relapse. Could you measure it then? I don't know. Like maybe you could. They're not really post-TB in the sense of they still need further antimicrobial therapy. So the way we're trying to handle that is just have people report when it was done, so that later the meta-analyses can be done to say, well, how did it vary, and how does that factor into the model?
Okay. Do we have another round of questions? Okay, there are lots of hands. We've got 1, 2, 3 here in the front there, and I've got 4 and 5 at the back. So we'll take the first 3, and then we'll take 4 and 5.
Is there room for oscillometry? I know we're trying to simplify, and I'm talking about another term, but in my experience doing the spirometry was a tremendous training, difficult. The oscillometry was learned just like that. So I want to bring that into the table and hear your opinion.
For me, I see radiologic abnormalities. You've left us pending. That for me, how are you going to parse that out? I know you've probably had discussions. That's the most fudgeable potentially, right? Because if you have CT scans, almost everyone has an abnormal CT scan after tuberculosis. So is it going to be a CT finding? And are we going to count, for instance, bronchiectasis the same as a few micronodules? How do you, well, looks like you have it, fibrosis, cavitation. Yeah, so that then, like, if you're... a question to you all is, do we think that the potentially, like the cavitation, for instance, if it's like a small cavitation, should, it sounds like maybe you do, count as much as the FEV1 to FVC that's less than, negative 1.64, and the fudgeability?
Yeah.
Hi, it's probably more a comment than a question, but it reminds me very much of the COPD definitions, and now you mention it, the pre-COPD, which we believe a lot of it has to do with small airways disease, which is incredibly hard to capture with these standard definitions. But there are criteria on spirometry looking at the very end of the plateau, for instance, or if you think about imaging in and expiratory images and so forth. I think it's important to at least think about it, because in the COPD world, we think that that's the stage where it can really intervene to try to change the trajectory of the future lung decline. And it's an interesting question if the same applies to post-TB lung disease, and if so, I think we should pay attention to small airways disease from these very early findings of lung abnormalities.
Great. Let's respond to those 3. Okay, so for oscillometry, I'll keep it quick. I'm not sure. Marika has mentioned and is developing oscillometry in her settings, and we do have a section that we're working on for the perspective that will eventually evolve into about oscillometry and new methods for assessing lung function. For the radiology question, if you look at the TB iris definition, there's a fair amount of clinical judgment that you have to use for that definition. So the INSHE definition is what I'm thinking about. It's really, at the heart of that definition is a clinician looking at the patient. So that's why with the TB treatment completion that are consistent with pulmonary TB sequelae. So someone has an FEV1, let's say, of the percent predicted of 60, and they have a couple granulomas in the apices of their lung, I would say as a clinician, I don't think that's not flying as an imaging criteria. So I think that since we don't know exactly what level or percent involvement, scarring, bronchiectasis, et cetera, really matter, I think what we're going to have to do is make some clinical sense. But the idea that there's a clinician looking at each patient and providing some adjudication kind of sounds like the IRIS definition that did, I think, enhance IRIS research. So I think it's going to be it's a clinical definition, I think, at heart. But I think as data evolve, maybe to some extent, you do this and maybe then it stimulates people to say, well, I'm not so sure about that. So let's take a look at it, let's maybe redefine it, and let's work on that part of the definition. For the comment, I agree. We're trying to, I'm not sure what to say, but it's a good comment. Yeah.
Yeah. So my question is about the consideration of the use of the GLI global. I'm here.
Oh, sorry. I was like, he's wearing a mask, and I couldn't tell if he was talking.
Yeah, so we do know there's some research which is coming out suggesting that the race-neutral equation will likely overclassify lots of abnormal cases. How do we plan to manage these? I know it's convenient, but it's likely to classify a lot of, especially sub-Saharan African population, as abnormal.
Oh, yeah.
Thanks. I kind of just wanted to piggyback a little bit on Jerry's, but I think, kind of classifying each of these abnormalities as necessarily equal. Whereas if somebody has an FEV1 to FVC ratio below 0.7 or a z-score below, that's a disease. So I think it's kind of, and if we're saying that it's due to TB, I would just maybe advocate or at least get your thoughts on, whether or not sort of spirometric abnormalities where we classify things as restrictive disease with a TLCO below, or obstructive disease, if we shouldn't really be kind of calling that disease, even in the absence potentially of symptoms. Whereas something like imaging, I would say also, how often do we see somebody with a scar from pneumonia? And we have historical precedents, although it's not TB, and I think we have to kind of, correlate some of our previous data as pulmonologists into the our thought.
I think mine is sort of related to what he said and what somebody said about whether a large cavity would equate to maybe small micronodules and his points. I was wondering, I know when you're coming up with definitions, you would want them, much as you want them to be relevant, you want them as simple as possible for use across different studies. But I think it runs the risk of bringing a lot of confusion when you say just the domains, PTLA versus PTLD. I don't know, I think, would we think of having severity gradings within the domains? Whereas instead of just saying, like, I can't remember who said, you have a patient with severe radiological abnormalities, but everything else is normal. But the severity of the abnormalities in one domain is quite significant, such that it may override one who has two minor abnormalities in two different domains or in all three domains. What about a scoring system within each of the domains based on severity, and then having a scoring system and then using that maybe to determine whether PTLA or PTLD? Thanks.
Okay, so maybe I'll go with that question first. I guess about the severity grading. So in preliminary analysis, I didn't have time to present here. I understand the concern. Let's say somebody has a huge cavity and then they're asymptomatic and they have normal PFTs. In our data set, in a limited number of people, most of the time that doesn't happen. So if someone has a big cavity or substantial radiographic abnormalities, they have something else too. Not always, so it's not going to be perfect. I don't know if we have enough data right now to justify a more detailed radiographic system. So I think, I think the way this definition could go out on a limb is to say, cavitation matters more than fibrosis and pleural thickening matters less than bronchiectasis. We just don't know that. The way I think that to handle it, again, it's about harmonization as much as it's about saying PTLD versus PTLA. It's about harmonization. So I think if we move towards some way of standardizing the way these are read, I think that could be included in a reporting framework and included in analyses. So I still think the definition is clinically intuitive because I think people with bad radiographic abnormalities have one of the other. And if you look at least in our data set, and I would welcome other people who want to look at this with us to put together data sets, if you look at them, a lot of these things are very correlated. And what you tend to miss if people have all three are people with very mild abnormalities. So for the GLI race neutral, I think GLI is better than NHANES. Like if we're looking at a Johannesburg population and the spirometer kicks out NHANES as a standardized tool, which sometimes is done, and often papers aren't even reporting what reference standards they're using, I think we're moving in the right direction with GLI Global. I don't know that it's the right way necessarily to do TB patients or not. Again, I think we need better data to do that. Hopefully by even having this discussion, it's getting people thinking about, well, how to define PTLD, and maybe we should do longitudinal studies. But I do think GLI Global, I don't know, I could ask our pulmonologists if we think global is better than one of the 4 specific populations within GLI. But I think they're all better than just the standard, the reference population is often used in studies. And I think it's good to report the reference standard that you're using when a lot of studies don't even report that. So the other question was about disease and the FEV1. I think if you say that someone had a ratio below 0.7 and had everything else that was normal, would that be disease? I can't say that it's not. I think right now, just in this definition, that would definitely be captured in both the definition and reporting. And again, I think that we would have to look at that and say, well, maybe a patient with an FEV1 FVC ratio 0.7 has the same progression, who has everything else normal, has the same progression as patients who have symptoms or have abnormal imaging, and you could follow them forward. If they have the same progression, the definition needs to change. But I think right now, if we had to say, I don't know, I'd ask you all, does it make sense to focus more on severe disease when you start combining these things, to have more than one thing together? We can report it all, but that's our bias was to try to focus on patients with more severe manifestations.
Because Greg took too long in his presentation, I'm going to allow one more round of questions. Naomi, James, and Matt. We'll try and get a bit of distribution of the room.
I just really wanted to say thank you to you and the team that have put this together, because I think it's so very important and will help the field move forward. One thing that I've observed in the pathogenesis literature in terms of trying to imply associations with more or less severe disease, whether that be PTLD or tuberculosis disease, is the inclination to grade radiographic severity and then take the median severity and classify anything above it as severe and anything below it as mild. And I think that's really the wrong approach, because actually what is happening is a lot of people that potentially have quite advanced disease are then being classified as mild, and then we're getting the pathogenesis wrong. And I just think this is the way forward in terms of getting us all on the same page. I almost wish we could do this better for TB itself, because I think that would also help when we're looking at predictors of PTLD, and I'm not sure the field is doing that particularly well at the moment.
James?
Thanks. I also echo, I think this is brilliant. I'm really excited by this, and well done everyone who's done it. I just want to echo some parallels with the early TB process, which Anna and Ryan and others were far more involved in than I was, and many people in this room involved in. And one thing is, we had a similar symposium like this and came up with definitions, and the terminology we came up with in terms of subclinical TB was decided on, agreed on, and it was only really when the WHO took it forward and did a lot of workshopping in affected communities that there was a sense that people weren't happy with that, communities weren't happy with that, they felt they didn't want to be labelled as that, and it wasn't clear. And I don't know if there's been a huge amount of community engagement with these terms, but I would just advise that that process takes place before you go firm on post-TB lung disease, that people who are going to be given this term like it and accept it.
Okay. Matt? Do you want to take this one, Matt?
Yeah, thanks, Greg. This has been great and really helpful. I guess my only question / suggestion is if you considered trying to do this more like a strobe guidelines rather than just a strict definition, because I do think there's so much heterogeneity across populations that, yes, you could publish like a research definition and encourage the people to follow that, but meta-analyses combine heterogeneous studies all the time. So I'm not sure that that's necessary that everybody uses the exact same definition, but if you say, in any sort of strengthening of reporting, these are the metrics that need to be reported out. So they would have the discretion and the ability to actually use every individual measure, not just one combined definition.
Yeah,
it's a good comment.
It's a great point, Matt. That's the idea behind the reporting framework, is that, and I didn't get time really to present the reporting framework in detail, but trying to keep it parsimonious and maybe a standardized set of metrics. So maybe, like for Sylvia's point, when were patients assessed, what instruments are used, what standards were used, and then have some basic metrics that are reported. So I hope that the reporting framework looks a little bit like strobe type thing. I mean, we don't want to get in the business of telling people how to report their studies too much, but we want to tell like maybe some minimum things to report so that we can compare across settings. So hopefully, you know, I want to emphasize there's two components to this, one of which we've been talking about today, the definition, but the reporting framework should capture anything. I mean, the definition here doesn't even classify patients into obstructive, restrictive, or mixed disease, but the reporting framework would. So hopefully that addresses that. Naomi, typically when we look at like CT severity associated with inflammatory biomarkers or biologic things, what we see is that, yeah, to your point, if you divide by the median, you don't really see much in associations, but if you take top quartile of people with CT involvement, those are the ones who have a lot of the the inflammatory biomarkers, the arterial stiffness or the symptoms. So I completely agree. Just dichotomizing at the median is too blunt. And James, for community engagement, I agree. I mean, I think you know, if we think about like, again, like the COPD and the GOLD network, there's so many people involved in that. I hope that we can create something similar for PTLD where we go forward and try to get community engagement. Really haven't done that yet, and I think that is needed.
Okay, I'm going to call time. This is an impossible task. This could go on all night, and I think maybe it can go on all night tomorrow night. I will extend it from 9 to 10 o'clock. There will be a session out back from 9 to 10 afterwards. We can carry on. Sarah has very kindly, Sarah, want to put up her hand, has very kindly agreed if anybody's got any burning questions that need to be considered, she'll happily write them down so we can document them and keep them. I think, Greg, you've managed to quite succinctly summarize a huge amount of discussion and backwardsing and forwardsing and going back and restarting and going on. So well done on that. I think it's a very exciting process.
Thanks.
And as I think, as you said a number of times, this is a road. It's a work in progress. As you said, with everything in our community, it's a work in progress. Until we get better data, this is how it is. It's going to change mics. So that's a wrap for today, everybody. Day one in the box. Well done. There has been a monumental amount of work on everything that has been done today. I think just take a moment to think about how much work has been done by how many people to get through this day and to get to this point. And when I say those people are us. We have done a huge amount of work. And so, I'm saying us. I'm saying us. I'm not saying us. I'm saying us. We've all done a huge amount of work. So please, as I said, this is your community. Get involved. Tomorrow is going to be a very exciting day. We've got the social functions, so bring some comfortable shoes. We've got the photographs, so do your hair and makeup like me. And so we've got the posters, which is going to be awesome. It's going to be a great networking session. And then tomorrow morning we'll start it at 8:30. We'll be kicking off at 8:30 again with plenary discussions, and we can go. So thank you for all your participation. Thank you for your engagement. Enjoy Stellenbosch tonight. It's a free night for delegates, so enjoy it. And thank you, everybody, for the day.